Now, Dr. Shambo, let's go to Dr. Shambo. Again, I'll request Dr. Shambo to be brief and to highlight the association between these two. One is COVID and I'm sorry, the steroids, which is the cornerstone of management of COVID this day, today, hospitalized patients, and then the fear of hyperglycemia, that is steroid induced hyperglycemia, and how to avoid it, number one, and then if it occurs hyperglycemia, then how to manage it. So it appears that somebody who is not known as a diabetic, when he is reaching the hospital, there are different possibilities that he has already started taking steroid, okay, and by the time he reaches, you find that he has hyperglycemia, and then how to actually approach this patient, okay. The patient is not a known diabetic, not a pre-diabetic either, but as he lands up in the hospital, you find he there is hyperglycemia, and at the same time he is on steroid. Then how to approach this kind of a patient? I would request Dr. Sambo to be a little focused and be brief so that we can have some discussion at the end. Thank you, Dr. Sambo, please.
Thank you, sir. Thank you very much. And I am very much thankful to Dr. Arindam Ray, who is a renowned endocrinologist in our city, for giving us time from his busy schedule. And he had beautifully covered many aspects of my talk also. Uh, and first of all, what sir has inquired regarding the guideline, I think government of India with AIMS endocrinology department, they had published one very good guideline on managing diabetic patients in COVID ward. And I think that is also available in net, and Dr. Arindam Ray has beautifully depicted some salient features of that particular guideline. And uh, we are going to discuss about steroid induced hyperglycemia in COVID-19. So here the word DM, that means diabetes mellitus, is missing. We are talking about hyperglycemia, but we all now facing one devastating epidemic that is known as mucormycosis. So devastating mucormycosis, uh, to control that DM, that means devastating mucormycosis, we need to give emphasis on how to control another DM, that is diabetes mellitus. And for that, there is no alternate to another two DM, that means dexamethasone and methylprednisolone. So we need some concrete evidence-based guideline to manage this milieu. So without any delay, this is why we require dexamethasone in treating our COVID-19 patient. So this recovery trial had clearly depicted the need of dexamethasone. Very recently, one trial was published in this journal, Clinical Infectious Disease Journal, May 2021. This particular study with methylprednisolone, this randomized control trial, that has suggested that short course of methylprednisolone in hospitalized patients with COVID-19 did not reduce mortality in overall population. So this trial gives a big question mark to what we are doing in our for last almost 1 year, giving or treating our patients, moderate or severe COVID-19 patients, with methylprednisolone or dexamethasone. But there are scientists who dissect this trial very well, and they had found that the glycemic equipoise was not there between two arms, and they suggest that is the cause. The diabetes is not controlled, and that is the cause why there is no benefit is seen in the methylprednisolone arm. So we need to tackle this issue, this the hyperglycemia, steroid induced hyperglycemia. Otherwise we lost our COVID-19 patient. And in this cartoon, we can beautifully see how they are interlinked, how COVID-19 and diabetes is very much interlinked. And for that, I always prefer to describe this with one mnemonic, that is COVID. That means while we are seeing our diabetic patient, we need to give emphasis on few aspects. That is C means we should check other comorbidities, maybe renal compromised, hepatic compromised, cardiac compromised. So we need to elicit history of comorbidity and coagulopathy in our diabetic COVID patients. Next is O, that means obesity. And for that, we know that obesity is directly linked with increased morbidity and mortality associated with COVID-19. Next is V, and for that, the viscosity of blood. That means we always know the D-dimer level goes up. So that is very critical things, and for that our diabetic patients need some protection against this increased viscosity, blood viscosity, and for that we generally use low molecular weight heparin, or in some case oral anticoagulant drugs, and some cases antiplatelet drugs like aspirin. Apart from that, I is very important, and it has been seen that by COVID-19 infection, COVID-19, the SARS-CoV-2 also affect the beta cell of the pancreas, because in the beta cell of the pancreas there is ACE2 receptor, and by that they decrease the insulin secretion. Apart from that, they produce another D, that means dysregulation of immune system, and that dysregulation of immune system also leads to insulin resistance. And apart from that, there are lots of cytokines that came into our blood circulation, which results in the hyperglycemia. So this synergistic action of SARS-CoV-2 and diabetes, so they cause increased mortality and morbidity, specifically when diabetes is not controlled. Now, while talking about steroid-induced hyperglycemia, this is one of the beautiful study which suggests that how the pattern of glycemic changes that has been seen with corticosteroids. So group 1, the lower, the cursor, is it seen, the cursor? So this triangular line, this is the group who are non-diabetic and they have no prednisolone. So you can see the features of the glucose level in their plasma. Now the second group, they are non-diabetic but receiving prednisolone. So here you can see at afternoon there is a surge in glucose level in the plasma, and that is the steroid induced hyperglycemia. And in diabetes patient, the non-diabetic patients who are who has given the prednisolone tablet, so there is increase in the post breakfast and post lunch, and even it persists somehow at the late hours also. So this is very important. This phenomenon is important, and this is why we need to control this glycemic surge. Now coming to few definition, what is steroid induced hyperglycemia? So use of steroid treatment in people with pre-existing diabetes resulting in worsening glucose control, and that is called steroid induced hyperglycemia. Now what is steroid induced diabetes? So that is rise in glucose occurring in people without a known diagnosis of diabetes. So they are steroid induced diabetes, and sometimes this is reversible when we withdraw or deprescribe steroids. Now I am giving a few real life scenario just to stimulate our respected delegates views, that if a 63-year female who had developed COVID-19 pneumonia, other comorbidities like hypertension, diabetes, now admitted in hospital at day 7 of symptoms onset, saturation 87% in room air, CBG at emergency room 340 milligram per DL. She was on vildagliptin plus metformin fixed dose combination twice daily, and there was a report on HbA1c 6.9% 3 months back. Now patient admitted in CCU. So what should be done for this glycemic control of this lady? So in this particular lady, I think the insulin infusion, starting insulin infusion immediately is the correct option for this particular patient, because already the CBG is high. Now we need this patient to start with corticosteroid, and for that there will be again a very high surge of CBG. But before doing the starting the insulin infusion, also we need to check the whether the patient has DKA. We need to check the urinary ketone body. We need to check the pH value. We need to check whether there is less bicarbonate level. So ABG should be done. So this particular patient, ABG reports was okay, normal. So urine ketone was negative. We had started insulin infusion, and as respected Dr. Arindam Ray had beautifully depicted about how we should titrate the insulin infusion protocol in hospital. So we had done that protocol, how to bolus dose, and then the titration of the infusion pump. I am not going in details, but that has been done for this particular patient. So next patient, a 48-year male, COVID-19 pneumonia, diabetes, hypertension, CAD, day 6 of symptoms onset, fever persisting, saturation 91% in room air, CBG at emergency room 246 milligram per DL, on sulfonylurea, metformin, empagliflozin, DPP4 inhibitor. Along with that, there is one HbA1c report. It was so 7.9%, not controlled as per this particular patient. We need much more control, particularly this patient. So patient admitted in ward. What should be done for glycemic control to this particular patient? So again, in this particular patient, we had started basal bolus therapy, and along with that, as this patient also need a glucocorticoid, dexamethasone. So we need to give one corrective dose of insulin prior to giving dexamethasone. Now another 36-year female, COVID-19 pneumonia, obese, BMI is 28, day 5 of symptoms onset, SpO2 was 90% in room air. The room air and the CBG at emergency room was 176 milligram per DL. Now patient admitted in ward. What should be done for the glycemic control? So whether this glycemic control is deranged or not, this has been, I am not going in details, because again Dr. Ray has beautifully mentioned about how to when to start with therapy. But what I want to emphasize in this particular patient, that we need to do follow-up CBG values, because this particular patient, when admitted, she was admitted at around 6 p.m. but pre-dinner CBG value was 160 in this particular patient, and 2-hour post-dinner CBG was 240. So we can see the importance of checking glucose in the COVID ward, and that we should not miss in any patient who are this type of thing. So this particular patient, again, she need dexamethasone, and for that again there is a surge of glycemic load, surge of glycemia, and we need some insulin to this particular patient also. We had managed this patient with 1 doses of NPH and another corrective insulin, short-acting insulin, premeal corrective short-acting insulins. So how to manage COVID patient on steroids? This is taken from the Government of India guideline. Why we need insulin therapy in COVID? We mentioned about that eye. And that I is very important because COVID-19 patients, maximum COVID-19 in hospital patients require insulin. So there is no alternative to that. And why is that? There is compromised beta cell function. There is, and that is also worsened by SARS-CoV-2 infection, as I had mentioned. By disease severity is directly proportional to the worsening hyperglycemia, and also the cytokine storm that worsen hyperglycememia. We need to give higher dose of glucocorticoids, that also related to COVID-19, that the related hyperglycemia. And how we should initiate insulin therapy. So this particular guideline gives emphasis on NPH in morning and or bolus regular insulin at lunch in patients on once a day morning dose of prednisolone, and full basal bolus insulin regimen in difficulty to control blood glucose or use of long acting glucocorticoid. But here I want to mention, in our practical experience, the use of prednisolone is very negligible in COVID-19. Generally, we use again that D and M, that means dexamethasone and methylprednisolone. And when we are using methylprednisolone, generally we use it 16 milligram twice daily. So this require a full-blown basal bolus insulin regimen. And how to titrate that insulin dose? Dose escalation is relatively more than the usual initiate in regular protocols. We need to give more dose of insulin, specifically when the patients are on a high dose of glucocorticoid. And what should be the blood glucose targets? Again, here is one thing. The targets are little bit compromised, we must say, because the fear of hypoglycemia. As we are dealing COVID-19 patients, the CBG monitoring is not that much like our other patients. So that cause we need to be little bit more protective regarding the hypoglycemia. So the target in this guideline, particularly, they had mentioned less than 220 milligram per TL, specifically the post meal. But it is always better to keep it between 140 to 180, and sometimes, if possible, if there is a stringent CBG monitoring, then we can make it 100 to 180. Insulin requirement changes dramatically with increase or decrease in glucocorticoid dose. So that is very important. And to understand this, I think this is a very beautifully done randomized control trial in New Delhi by Dr. Om J. Lekhani and Professor Sudhir Tripathi. So I want to discuss a little bit on this protocol, because this protocol can help us regarding managing our steroid-induced hyperglycemia patient in a COVID-19 ward. So the basis of this protocol is that giving an additional correctional insulin which matches the glycemic profile of the glucocorticoid administered, and that would negate the glycemic effect of the glucocorticoid. So just the pharmacokinetic pharmacodynamic matching with a glucocorticoid and a specific insulin, that can give some huge benefit. So I am not going in details. You can find it in from net, that how they divide different groups. So first of all, if the patient is not a diabetic patient, so in that case, that is the HbA1c level is less than 6.5%. And as Dr. Arindam Rai has rightly mentioned, the importance of measuring HbA1c in the next day of admission. So we need to check HbA1c to understand whether the patient has pre-existing diabetes, or if the patient has diabetes which is controlled or not. So HbA1c has a very huge value. So we need to know what is the HbA1c level, and then we need to know whether the patient is non-diabetic, whether the patient is diabetic but it was undiagnosed. Then the question comes whether the patient is non-diabetic but not on basal bolus insulin. Then the last column is that non-diabetic on basal bolus insulin. Now we have to decide as per the HbA1c value. I am just giving one example, that if a patient come to us with a HbA1c value of say 5.8%, and there is a steroid induced hyperglycemia, and we need to give methylprednisolone to that particular patient. So how we can tackle that patient? So if it is less than 6.5% and the patient is not known diabetes, so we can give one dose of correctional insulin along with that methylprednisolone, and that can be NPH with that methylprednisolone. If I am giving methylprednisolone once daily, that can take care of the whole glycemic load. So if again another example, if a patient come to us with an HbA1c value of say 7.9%, and he is non-diabetic but not on basal bolus, now we can, what thing we can choose? So you can see here, we need to give first one background insulin, and that should be started with 0.4 unit per kg dose, and along with that 0.4 unit per kg dose means if his body weight is 60 kg, so we need to give 24 unit of insulin, and if we are using analog insulin, then we need to divide it in 50%, 50%. So 12 unit basal insulin, maybe glargine, and 12 unit bolus insulin divided into 3. That means before breakfast 4, before lunch 4, before dinner 4. So 12 versus 12. Along with that, we need to give a correctional insulin administered along with that particular glucocorticoid. If I am giving this particular patient dexamethasone, we need to give a long-acting insulin along with that particular dexamethasone dose. So what should be that particular dose? I am coming in a later slide. So I think this protocol has clearly mentioned how we can we can use insulin in patients who are diabetic and need corticosteroids. Now, what should be the starting dose for total calculating the insulin dose? If it is less than 6.5%, we can start 0.3 unit per kg for those who are non-diabetic. If it is 6.5 to 8.5, it can be 0.4 unit per kg. More than 8.5, it can be 0.5 unit per kg. But we should always respect that if a patient has compromised kidney function, age is more than 70 years, the starting dose should be little bit lower, maybe 0.2 unit or 0.3 unit per kg. And how we can change the basal insulin dose? They had used this formula. If the next day fasting blood glucose is more than 200, they increase the basal insulin dose by 20%. If it is between 140 to 199, then increase basal insulin dose by 10%. If it is between 70 to 100, then reduce the insulin dose by 10%. And if it is less than 70, reduce basal insulin dose by 20%. So the optimum fasting blood glucose, target fasting blood glucose, is between 100 to 140. Now CBG monitoring, in this particular trial, they had done 4 times a day fasting, pre-lunch, pre-dinner and bedtime using a glucometer. And the target that I had already mentioned, the pre-meal was between 100 to 140. The post-meal, or they specifically target the bedtime blood glucose, that means 2 hour post dinner blood glucose, that should be between 140 to 180. And they also used a supplemental dose of pre-meal insulin. So that means, as they had checked the fasting, pre-lunch, pre-dinner, so as per the fasting, pre-lunch, pre-dinner value, they had given some supplemental insulin dose of regular insulin or analog insulin along with what was calculated before. So this was the supplemental insulin dose. So it has been generally used when the patient is on hydrocortisone. The pharmacokinetic, pharmacodynamic parameters are matched with regular human insulin. If it is prednisolone, then insulin NPH, and methylprednisolone also insulin NPH can match. And if we are using longer acting like dexamethasone, insulin glargine and insulin degludec, has a matching property with pharmacokinetic and pharmacodynamic characteristics of dexamethasone induced hyperglycemia. And this is this dose relation is also very important, because how much correctional insulin I am going to give. So now for that, we all know this formula, that dexamethasone 2 milligram is equivalent to prednisolone 8 milligram, methylprednisolone 8 milligram, prednisolone 10 milligram, and hydrocortisone 50 milligram. And so for each 2 milligram of dexamethasone dose, we need to give one correctional insulin, 0.1 unit per kg. So assume a patient who needs 8 milligram of dexamethasone. So for him, that we need to give a correctional insulin glargine or insulin degludec of 0.4 unit per kg. If the body weight is 60, so we have to give 60 into 0.4, that means around 24 unit correctional insulin, along with that particular dose of steroid. So this was the thing they had mentioned, that they had used, and they had clearly shown the benefit in terms of the glycemic variability, lesser hypoglycemia, and much more control. That time the time in range concept is not there that much, but they had shown there is clearly benefit in favor of this particular protocol compared to the conventional protocol. So this was a very I think a very useful tool even nowadays, because we need to use corticosteroids. There is no other option, so we can follow this guideline, follow this protocol, and we can see, and there we can plan another research also in this using this this protocol, whether it is matching in our day-to-day practice also. So this is I think very important. And now I am going to that particular guideline, which was also beautifully mentioned by Dr. Ray. I am not going in details because already Dr. Arindam Ray had covered this topic. So this generally giving the emphasis on when we should start treatment. And you can see, first we have to check a CBG at the time of hospital admission. Then we need to perform a pre-meal and 2-hour post-meal CBG with the first major meal in the hospital, just like I had shared our that 36-year female patient whose entry CBG was around 178, like that. But when we checked the pre-dinner and 2-hour post-dinner CBG, it was high. So we need to send the blood for fasting plasma glucose and HbA1c next morning, and then we should check these numbers. So we need to monitor CBG before breakfast, before lunch, before dinner, and after dinner for at least 2 days for underlying hyperglycemia if any of the test values are high. So we need to check the patients, and if there is any random CBG value more than 180, pre-meal more than 140, post-meal more than 180, and the fasting value more than 110, HbA1c becomes more than 6%, and we need to be we need to give a vigilant eye on this particular patient. But pharmacotherapy requires, if the random CBG is more than 250, pre-meal more than 150, post-meal more than 200, fasting more than 126, and HbA1c more than 6.5%. And as I had already mentioned, we need to do the ketone body test, urinary ketone body test, check the pH and bicarbonate level if the CBG at any time more than 250 milligram per DL. So we need to be very clear on that. We should not miss diabetic ketoacidosis patients. So blood glucose monitoring strategy for individuals with no evidence of stress hyperglycemia or undiagnosed diabetes at the initial screening, this has been already mentioned. And we need to give, even the patient CBG is normal, but patient is initiated on steroids, we need to give emphasis on this CBG monitoring. And this CBG monitoring should be done daily, and at least for initial few days, and it should not be decreased if we have enough feasibility. And these are the other patients where we need to monitor blood glucose twice a day, every 3 to 4 days. but patients is on steroids, we need to check all these levels before breakfast, before lunch, before dinner, and after 2 hours after dinner. So guidance on the use of insulin therapy in our guideline, in Indian guideline, they had clearly mentioned prescribe insulin if there are contraindications to oral glucose lowering agents, or the patient is suffering from moderate to severe COVID or moderate to severe hyperglycemia. That means pre-meal more than 180, post-meal more than 250. Now, I think all the patients who are now admitting in our hospitals, they are suffering from moderate to severe COVID. So ideally, as per the guideline, they should fit in this insulin therapy group. And when we require intravenous insulin infusion, it has been beautifully discussed. I am not going in details. And when how to use basal bolus insulin regimen, we had already discussed and in our previous slides. So now, while using steroids in Government of India guideline, they had also classically mentioned when to use which insulin and what are the different other conditions. So if there is no previous diabetes, but there is hyperglycemia, so we need to give 0.2 unit per kg per day. So one dose of NPH, 0.1 unit per kg, morning dose, along with that dexamethasone or methylprednisolone. But I think there may be debate with that, what I am talking now. But I think when we are using dexamethasone, which is a prolonged acting drug, we need some analog insulins like glargine or degludec. But when cost is a constant, NPH is also very good. So regular insulin, 0.1 unit per kg before lunch. So the dose is 0.2 unit per kg per day. Morning dose NPH, 0.1 unit per kg, along with that particular steroid administration, along with regular insulin, 0.1 unit per kg before lunch. Because again, if we just revisit that diagram, that steroid-induced hyperglycemia pattern, we always know that the afternoon, 2-hour afternoon, 2-hour post-lunch is that period when there is maximum glycemic surge happen. But when the patient is already known diabetic, already on 1 or 2 oral glucose lowering agent, then the dose should be 0.4 unit per kg per day. And here we need to give NPH 0.1 unit per kg, a morning dose and evening dose, along with regular insulin 0.1 unit per kg before breakfast, before lunch, and before dinner. So when to give that NPH 0.1 unit, because here NPH 0.1 unit per kg is one dose only. So generally it is preferred, it should be given along with that particular steroid what we are using. But again, I am mentioning here, it is if we are using methylprednisolone twice daily, or if we are using dexamethasone tablets which are prolonged acting, it is generally better to use long acting insulin analogs. Now, when the patients already on more than 2 oral glucose lowering agent, they require higher units, so 0.6 units per kg per day. Here they require 2 doses of NPH, 0.2 unit per kg morning dose and 0.1 unit per kg evening dose, along with regular insulin 0.1 unit per kg before breakfast, before lunch, and before dinner. So this is the formula. And diabetes on insulin more than 0.6 units per kg per day, already patient is taking a huge amount of insulin. Now what to do? Now the dose calculation is like that, we have to give 20% extra to that particular patient. So 1.2 into patient's insulin dose units per kg per day. So we need to multiply 1.2, and again here we need 50% NPH, and for that 2/3 NPH dose will be given in the morning, 1/3 will be given in the evening, and 50% regular insulin divided into like that before breakfast, before lunch, and before dinner. And we need to monitor the sugar level. So when the patients are on insulin and they have steroid induced hyperglycemia, we need to check the CBG like this log. So we have to enter the glucose value, we have to enter the insulin dose, and we have to also mention here date-wise the steroid dose. Because as the steroid requirements decreased, there is a marvelous response in the insulin dose requirement. So the insulin dose was so much decreased along with that steroid dose decrease, tapering of the steroid dose. So these are the times 3 a.m. value is important only when there is fasting hyperglycemia. If our patient is having some fasting hyperglycemia, it is important to see whether the patient has Somogai effect or Dawn phenomenon. So that can be that can be seen if we check the 3 a.m. CBG value. What should be the advice on discharge? Those patients who are on this type of steroid-induced hyperglycemia, so who maintain their blood glucose levels with oral glucose lowering agents during admission, we can continue same medications and discharge. Who were on basal bolus insulin and the dose is very high, that means that particular patient require more than 1 unit per kg per day dose. So same insulin regimen itself we can prescribe while discharging with some reduction in the total insulin dose. We need to consider if we are deprescribing steroids completely, so there is a gradual reduction in the insulin requirement. But individuals on insulin dose, moderate insulin dose, that means 0.5 to 1 unit per kg per day dose. So they require, we can prescribe them twice daily premix insulin and oral glucose lowering agents along with that. Patients who required only low dose insulin, low dose means here less than 0.5 unit per kg per day, and there is no other medications to control that particular hyperglycemia. So these particular patients can be discharged on different oral glucose lowering agents like DPP-4 inhibitors, metformin, sulfonylureas, after careful considerations of drug safety, patient-specific factors. And there are some studies also with SGLT2 inhibitors post-COVID. I am not talking about acute ill COVID-19 patients. Post-COVID-19 patients, they can be the SGLT2 inhibitors can be used with checking the other safety issues. So, summary of today's presentation: there is positive results from recovery trial that tell us that the need that emphasize the need of glucocorticoids among patients with moderate to severe COVID-19. So we need to prescribe glucocorticoid. There is nothing like that. My patient has high blood glucose, so we have to wait with insulin therapy for 2 to 3 days. Then the glucose value will go down. Then I will try to inject glucocorticoid. No, that is wrong. If the patient requires glucocorticoid, irrespective of CBG value, we should start glucocorticoids. Along with that, we need to give emphasis on glycemic control with insulin. That insulin dose can be titrated, but there should not be any delay in while starting glucocorticoids when it is really needed. So high dose glucocorticoid, they increase the risk of hyperglycemia, but we have insulin to counter that. So previously well-controlled diabetics sometimes require large dose of insulin, maybe more than 2 units per kg per day. That can be happen, but we need to have insulin and steroids matching with them with their pharmacokinetic and pharmacodynamic properties, and we can use easy guidelines to help our patient. So for patients with uncontrolled hyperglycemia, despite the use of basal bolus regimen, the use of intravenous insulin infusion should be considered, and there should not be any delay in starting intravenous insulin infusion. And there are beautiful protocols with that, how to use insulin infusion. So with that, I thank you. I again want to thank Professor Shantanu Kumar Tripathi sir and Dr. Arindam Ray sir. And we today I think there is some preoccupied things with Professor Shashank Joshi sir, so he is not able to present till now. So I am thankful to him also. Over to you, sir.
Thank you very much, Dr. Samasdar, and you have very elaborately discussed yourself and Dr. Arindam Ray. There is hardly anything left really to emphasize any further, but particularly the Government of India guideline that has come quite recently, and to what extent this is being implemented, okay, at the hospital level, that is to be seen. To the best of my knowledge, there was no separate guideline in West Bengal, at least from Government of West Bengal. I don't know there if there is any guideline. This Government of India guideline, whether it is being implemented in most of the, or if not all of the hospitals for COVID management, that needs to be seen. And at the same time, I would again harp on both Dr. Roy and Dr. Shambhu Samasdar, that can you think of taking the principles? Can you think of a more simplistic kind of guidance document for the COVID hospitals, where I believe now that most of the people who are actually at the helm of affairs in managing on a hour to hour basis, they are actually non-specialists. So more simplistic kind of guideline, algorithmic, that would be really helpful if it can be done. I would also request if whether we can do this from iNovoCare platform, that also you may consider. Both of you can take the responsibility, and we can have a small group, and then we can have one or two more experts. Dr. Shashank Joshi was not available today. We can also take his help in formulating a simpler kind of, the skeleton might be, the principle might be the Government of India guideline. Secondly, I'm not sure whether I have seen it correctly, that you have, while you defined that uh, steroid induced hyperglycemia has to be by definition in diabetic subject. So if somebody who is non-diabetic or pre-diabetic and land up with hyperglycemia, what do you call them? So, and then in second case, we have said that if hyperglycemia is steroid induces hyperglycemia, can you go to that particular slide? There was one slide in which you have the, I think the third or the fourth slide, Dr. Samasdar, you had shown the definition of steroid induced hyperglycemia. But then somebody who is a non-diabetic, neither a pre-diabetic, and then if he has started steroid, there are two factors. One, the stress of COVID itself, it's an acute infection. And again, there is steroid exposure or steroid being given, whatever be the dose. Now, together, as I believe, as I understand, that should be enough to actually lead to hyperglycemia or rise in glucose. So, what do you call it? It is a drug-induced hyperglycemia. Now, if you define that it is only when the person is pre-diabetic or diabetic, then only you call it steroid-induced hyperglycemia. I don't know really whether I have
In this
understood it.
particular article in the Diabetes
Uh,
Journal of Diabetes and Medicine, Diabetes Medicine Journal, Roberts A. et al. So he had defined like that what you are saying, that is actually a steroid induced diabetes, and they had mentioned that the rise in glucose occurring in people without a known diagnosis of diabetes. So there can be pre-diabetes, they can be already they have may have diabetes, we don't know. But here the differentiation is with that
no, no.
particular
Tell
HbA1c
me.
value.
No, no. Tell me what they have defined. Steroid-induced hyperglycemia. How do you define it?
So they had defined that use of steroid treatment in people with pre-existing diabetes resulting in worsening glucose control. So this is a
But
simplistic definition.
if somebody does not have a pre-existing diabetes,
So that is
yet they are in
steroid induced
hyperglycemia,
diabetes.
that
So
is not
that
steroid induced. What do you call it?
that is steroid induced diabetes.
No, it's not steroid induced hyperglycemia. You mean?
No, no, no. That is if the patient does not have pre-existing diabetes without a known diagnosis of diabetes, and if there
Right?
is a rise in glucose, then it is steroid-induced diabetes. And steroid-induced diabetes is a entity which is also reversible sometimes,
Okay.
or we can say drug-induced diabetes, like that.
Okay. But then, by common sense, it would have been the other way around. That if it is hyperglycemia caused by steroid, it is steroid-induced hyperglycemia. Okay. If the patient is otherwise diabetic or pre-diabetic, and because of poor control prior to getting COVID, or even after getting COVID, poor control, and landed up in a hospital with hyperglycemia, that is poor controlled diabetes, and then steroid is an additional factor that has caused this
Yeah,
hyperglycemia.
sir.
In any case, that's a debate,
Yeah,
but then we need to look into it. But you are very nicely, you have also described the chronopharmacodynamics of hyperglycemia because of these two factors, and how the if one can plan also, and the additional dose of the insulin whenever you are going giving the steroid. So that is also very important, and it is very, I appreciate really when you talk of dexamethasone has a relatively longer effect so far as its impact on the on the glucose level is concerned as compared to methylprednisolone. There is also another factor, and that is the circadian rhythm, and how you are adjusting with that circadian rhythm. Methylprednisolone you are giving twice, and dexamethasone I think you are giving only once. And if you are giving once, what time you are giving, that is also important. But there is a lot of scope for research in this area. And two things as I leave, two things I will be emphasizing on. One, devising a relatively simpler kind of guidance, which uh, generalists would be able to really implement under the uh, very highly difficult environment of patient management, okay, in a COVID ward. And secondly, uh, doing little bit of research, how really diabetes or hyperglycemia is being managed. We can say many things, but then how and to what extent it is really being done, okay, on the field. So whether we can also try to generate some data on that, okay. With these two asks rather from two of you youngsters, I would leave here. I would have loved to remain and engage in further discussion, but I have another preoccupation. I have to join in another webinar right now. Otherwise, you have done a marvelous job, both of you. Thank you very much, and wonderful presentations. And I think all the people who have listened to this, they have thoroughly enjoyed and benefited. And I suppose this will also be available, the recorded version, that those who missed it, they can also join later. Thank you very much. Over to Rohan.
Thank you so much, Dr. Tripathi. Thank you so much, Dr. Rai, Dr. Shamajdar, for this wonderful evening. But I would be really happy if we can continue with what Dr. Tripathi said, and actually, instead of ending this as a one evening of discussion, and taking this forward to something even more concrete and something that can be taken out in another platform, can be showed to people, and can be used to help people. We are still helping people with all the wonderful talks you gave in spreading awareness. But I think if we can actually come up with a guideline or protocol that can actually help in uh, management of this disease, then that could be an even more worthwhile use of the, and it would even take the meaning of this evening even further. So that remains my humble request to all of you. I, in my own abilities with iNovocare Health Hub Solutions, will try my level best to assist you people in any way you want me to, in order to make this happen. We can, I can also reach out to other doctors. If you tell me whom to reach out to, we can definitely do that, and it would be my honor. Dr. Shamazdar, yes.
I have one request to you, because I know your technological efficiency. So there is one calculator specifically how to manage the insulin infusion rate in hospitals. So I
Okay.
request you also to see that matter, and whether this can be done in our setting and we can offer to our doctors. Now in every ICU they have their tab. So whether that type of software can be included in that particular tab, and we can optimize our patient care, specifically diabetes patient care. So I request you to please nourish this matter.
That would be great actually. We are,
Okay.
it would be, we would look into it definitely. I promise you that. So it's great. It's a wonderful input that we got today. So with that, I think we have already moved half an hour past our scheduled time. So but it did not
Thank
feel
you.
even one moment extra due to our speakers. So I'm really thankful to all of you for joining tonight. Thank you so much once again, Dr. Roy, Dr. Samazdar, and Dr. Tripathi. So with that, we will say good night for tonight,
Thank you very much.
and we
Thank you.
will
Thank you. Good
surely
night.
come back very soon with another
Thank you.
program. Thank you so
Thank
much.
you. A special
Thank
thank
you.
you
Thank you.
to
Thank you, Dr.
Orindam
Rai.
da.
And
Orindam da.
thank you
No,
so
no,
much,
not to
Dr.
mention
Rai,
at
Yeah,
all.
for
of course.
That's not a problem.
being there
Thank you. Thank you,
Okay.
everybody.
and
Stay
arriving.
safe and good night.
And I would like
Thank
to
you.
also mention for everyone there that Dr. Rai arrived at a very short notice. He came to our rescue,
Yes.
and so that for that we are especially very thankful to him. Thank you so much, sir.
Yes, of course.
Thank you. Thank you, everybody.
Thank
Good
you.
night.
Thank you.
Good
Good
night.
Good
night.
night.